Hi, my name is Koushik K, and I'm an associate professor in the Division of Gastroenterology at Washington University School of Medicine. On behalf of my co-authors and collaborators from the Mayo Clinic in Rochester and WashU, I would like to discuss a recently published paper in gastrointestinal endoscopy entitled Clinical Predictors of Significant Findings on EUS for the Evaluation of an Incidental Common Bile Duct Dilation. Given the advent of ubiquitous cross-sectional imaging in an ever-aging population, incidental common bile duct dilation is an exceptionally common finding, though it remains difficult to define, as some societies suggest a threshold of 6 to 8 millimeters, others 8 to 10 millimeters, and others still advocating for thresholds based on patient factors such as age or cholecystectomy status. In one prospective cohort of 1,386 patients undergoing MRI-MRCP, nearly 25% of patients were identified as having a dilated bile duct without an obvious cause. Notably, in this study, over 3 years of follow-up, only one patient was diagnosed with choledocholitis and two with pancreatic cancer of a cohort of 1,386. Numerous other papers have echoed these findings, namely that CBD dilation is very common, and while the vast majority of cases are due to benign etiologies like senescent changes, post-cholecystectomy reservoir status, periampullary duodenal diverticulum, medication use such as narcotics, or idiopathic causes, there is a real, albeit very small, risk of an occult ampullary pancreatic or biliary malignancy as an etiology for this finding. In this setting, we leveraged serial patients undergoing EUS examinations for the evaluation of an incidentally dilated common bile duct at two large quaternary referral centers, WashU and the Mayo Clinic in Rochester, over a decade. Given the significant subjectivity in radiological thresholds for dilation, we confirmed that the CBD was at least 6 millimeters if no numerical value was provided. We excluded patients with right upper quadrant or biliary type pain, prompting their index imaging, LFT elevations 3 times the upper limit of normal, concomitant pancreatic duct dilation of 5 millimeters or more, prior history or evident new diagnosis of a significant pancreatic biliary disease, or the identification of an obvious cause to the common bile duct dilation on imaging, like a mass lesion. Of 1,399 screened patients, 375 met inclusion criteria for analysis, with patients being predominantly white and female. The most common indication for index imaging was non-biliary, meaning non-right upper quadrant, abdominal pain in 44% of patients, followed by hepatoma screening in 4.5%. A significant number of our patients had chronic abdominal pain syndromes, approximately 20%, as is common in large GI referral practices, and concomitantly, opiate or Suboxone use was also common in nearly 18% of our patients. EUS examinations were completed successfully in 100% of patients with a yield of clinically significant findings in 8.3%. That is, 31 out of our 375 included patients had a significant finding on EUS. Of these EUS examinations, 26 patients, or 6.9%, were found with stones. 1, or 0.3%, was found with an ampullary adenoma, and 1, or 0.3%, was found with a small pancreatic head mass. This is a critical finding, namely that the likelihood of finding a malignancy in this low-risk population with essentially normal LFTs, no pancreatic ductal dilation, and a normal pancreas on imaging is exceptionally low at 0.3%. Patients who had clinically significant findings on EUS were significantly more likely to have a prior ERCP, be above the age of 70 years, and have acute non-right upper quadrant biliary type pain, underscoring that clinical assessments of biliary type pain syndromes are imprecise. There were no differences between significant EUS examinations or normal EUS examinations based on index imaging modality, meaning abdominal ultrasound, MRI, or CT, or the use of medications like narcotics, calcium channel blockers, benzodiazepines, and others, though the baseline usage of these medications was high in our cohort. Given the established literature on the role of prior cholecystectomy on CBD dilation, we established a threshold of CBD dilation of greater than or equal to 15 millimeters in patients with a gallbladder in situ and 17 millimeters in patients without a gallbladder in situ as predictive of a significant finding on EUS. This is a very important finding, as pathologic bile duct dilation is labeled by many radiologists starting at 6 to 8 millimeters, but our data demonstrates that dilation predictive of a meaningful finding in this low-risk group is more than 2 times that threshold. We then perform multivariable analysis to develop a clinical risk prediction model with the goal of creating a tool that can exclude the possibility of a clinically significant finding, meaning having a very, very high sensitivity to identify the patients who truly would benefit from an invasive EUS examination for this indication. The risk tool awarded 1 point for age above 70, 2 points each for acute right upper quadrant pain without a history of chronic abdominal pain syndrome, prior ERCP, CBD more than 15 millimeters with a gallbladder in situ, and 17 millimeters post-cholecystectomy. We found that having a score of greater than or equal to 1 had a 92.3% sensitivity in the WashU cohort for identifying patients with significant findings. Externally validating this on the Mayo Rochester cohort, the sensitivity was 100%. We performed cross-validation using a combined dataset with 1,000 bootstrap replicates and found a sensitivity of 93.5%. In this combined cohort, 117 patients, or 31% of the whole study population, had a score of 0. Only 2 of these 117 had significant findings, none of which were malignancy or adenoma. Inversely, a score of 4 or more had a specificity of 92 to 94% in the development, validation, and cross-validation cohorts for being significant in predicting pathology present on EUS examination. This large multi-center cohort, building upon prior reports, should provide reassurance to physicians and patients alike about the likelihood of significant findings in the evaluation of incidental common bile duct dilation, even with minor insignificant LFT elevations. The prediction model developed here could potentially reduce overutilization of EUS in patients who are unlikely to harbor meaningful pathology, while maximizing the efficient delivery of care to patients who are more likely to need intervention. Using our cutoff score of 0, we were able to exclude nearly 1/3 of patients from examination with an exceptionally high sensitivity and negative predictive value. As EUS may cost several thousands of dollars and nearly 25% of MRIs are estimated to have an incidentally dilated bile duct, the potential cost savings for a health system is significant. While EUS is very safe, with a 1 to 4% complication rate, given the risk of sedation in a generally elderly, infirm patient population, minimizing low-yield diagnostic procedures is very important. Conversely, if a patient had a score of 4 or 5, it may be important to perform EUS in a setting where ERCP can be done concomitantly, given that more than 90% chance of a significant finding being present. In conclusion, less than 10% of patients undergoing EUS for incidental common bile duct dilation in 2 large centers across a decade had a clinically significant finding on EUS, with less than 0.5% harboring a malignancy. Moving forward, expanding and further externally validating our simple clinical prediction tool may hopefully allow for the more efficient evaluation of this clinically common group of patients.